From Diamond Pharmacy and Optics, this is PodcastRx with Chris Bender. When he's not on the mic, Chris is a clinical pharmacist with the Office of Pharmacy Therapeutics and Integrated Clinical Services, or Optics. He routinely helps providers in correctional and long-term care facilities make better medication decisions to improve patient care. And we're so happy that he's sharing his expertise with you.
Hoping that today can be a real knowledge booster.
A classic Batman and Robin or Jordan and Pippin type scenario.
A full armamentarium of options that clinicians can choose from.
Chris is heading to the Spring NCCHC Conference in Louisville, Kentucky to give a presentation on overweight and obesity management in the correctional setting. As revolutionary weight loss treatments take hold in the community and in the popular consciousness, Chris is seizing on the moment not to just talk about GLP-1s, but to review weight management as a whole, pharmacologic and non-pharmacologic treatments, special considerations for the corrections environment, and much more. We take a sneak peek at his presentation and talk about what he hopes attendees will take away from it. I'm Adam Campbell, and this is PodcastRx with Chris Bender.
Hello, Chris. It's good to be back with you again. You know, we had a little bit of an unplanned hiatus for February, some organizational changes happening on my end. And of course, you in Optics, you guys are always, have a lot happening. You guys are always busy. So how are you? Happy spring.
Yeah, absolutely. Happy spring to you too. I mean, listen, I was just thinking everybody hunkers down over the month of February anyway. So we just did, it just kind of followed suit. But no, I've been really good. I've been getting out and about, finally enjoying some of the nice weather that we've had, albeit I'm staring outside of a very rainy window today. But no, I've been good. I'm glad to get back on with you.
Absolutely. Yeah, likewise. And yeah, what Chris is describing here in Western Pennsylvania is what we call fake spring. We just had a round of it, and I think we're going to go back to reality. I mean, in all fairness, though, we really shouldn't be having 80 degrees in the middle of March, so it's going to kind of correct down to like the 40s and 50s where it should be. That's still not bad.
We didn't deserve it, but it doesn't mean I don't want to keep it.
Exactly. And as we're saying, I apologize to the listeners for the missed episode, for not getting a February episode out. Actually, we were planning to bring on longtime listeners know him, but anybody new to the show, Henry So, who is a colleague of Chris in the Optics clinical pharmacy team. We were going to bring on Henry for a Heart Month inspired debate, talking about the ideal blood pressure goals. And but because we're so close to April, Chris has a big event on the calendar that we would be remiss to not talk about. So we're going to get into that today. As far as that debate with Henry, we're going to revisit that in a subsequent episode. And Chris, I know you guys are really sharpening your swords for that debate. So I'm sorry we had to postpone it.
Yeah, I'm sad Henry has to take the gloves off for a little while, but we'll get back to it. It'll be fun whenever we do it.
Absolutely. Well, as I just alluded to, we're a few weeks out from the Spring NCCHC Conference in Louisville, Kentucky. And NCCHC, of course, the National Commission on Correctional Healthcare. Always a big show on Diamond's calendar, trade show-wise, but also it's a big show because that gives our clinical pharmacists like Chris the opportunity to present on relevant healthcare topics germane to the correctional healthcare industry and pharmacy care. And longtime listeners of this show know that you've presented at NCCHC many times. We've done quite a few preview episodes to explore not just the presentation that you're about to give, but also a little bit the topic at hand that you'll be presenting on. Most recently, I think we talked about inhaler treatments and how there were like 37 different types of inhaler treatments.
There were enough.
Yeah, so today's going to be another one of those days, and we'll get into that topic momentarily. But first, we have to take a look at the month's most important medication news with a trip into the clinic.
All right. So typically, this segment is a brief review of the previous month's headlines. But of course, since we missed February's show, I'd be remiss if I didn't mention the approval of suzetrigine, which is sold under the brand name Journavx. Specifically, it's been approved for the treatment of moderate to severe acute pain in adults. And much of the hype surrounding this medication is due to it being the first pain medication approved in over 20 years. And also the fact that it's not an opioid, making it an appealing, non-addictive alternative. So basically, Suzetrigine works by inhibiting the transmission of pain signals from the peripheral neurons to the brain by blocking a specific sodium channel, that being the NaV1.8 channel. Now, interesting side note, this is actually one of the channels that lidocaine inhibits. Listeners may be much more familiar with that, although it inhibits it much less selectively and much less potently than suzetrigine. But anyway, Journavx's approval was based on the results from two trials. So one that was post-abdominoplasty, or commonly referred to as the tummy tuck, and another being post-bunionectomy. Patients were given either Journavx, hydrocodone acetaminophen, or placebo for 48 hours after surgery, and their pain ratings were obtained at 19 different time points during those 48 hours. So these pain ratings were then tallied to give a cumulative pain score for each treatment called the SPID-48, which essentially allowed for a direct comparison between the three different treatments. Now, the results showed that Journavx reduced pain by an average of 37.8 points more than placebo after abdominoplasty and 36.8 points more than placebo after bunionectomy. Now, of course, while this is a significant reduction, it's important to remember that this is a cumulative number. And at any given point, the actual pain reduction was more like an average of 2 points lower with Journavx. It's also important to highlight the fact that despite being included in the trial, Journavx was not statistically compared to hydrocodone acetaminophen. And additionally, the trial did not include other traditional therapies like NSAIDs with or without plain acetaminophen or Tylenol. Now, to be clear, I think this is I think it's fantastic that advancements are continuing to be made in pain management. However, it's important to acknowledge these potential limitations, especially in light of the potential cost of the medication, which the company has said will be about $15.50 per tablet.
Oh, that is quite the sticker shock there with that price, but
Yeah.
but no less, this is a monumental development of, the first in 20 years for pain, and
Yes.
important to keep in mind of all the things you said, that this was approved for acute pain, and we're not talking about chronic pain. But
Yes.
either way, as we like to say on here, another weapon in the armamentarium.
Exactly. I'm a big fan of always having another arrow in the quiver, but there was actually interesting, just a quick side note, they did do a study for more of like a chronic type of pain condition. I want to say it was low back pain, but I'm not 100% certain. Basically, they didn't see a statistically significant effect. But that's not to say that maybe a longer duration of study or a different type of study design. It's not to say that there may not be benefit out there in the future for a chronic pain designation. But point being, I think this just shows you that the pharmaceutical industry is interested in developing new and alternative methods to treat pain. And I think that's going to be important moving forward. So it's just exciting news all around.
Absolutely.
Now, in other news, Ozempic, a GLP-1 agonist, has gained an expanded indication to lower the risk for worsening kidney disease, kidney failure, and cardiovascular death in individuals with type 2 diabetes with established chronic kidney disease. Now, this was based on results from the FLOW trial, aptly named, in which those taking Ozempic had a 24% relative reduction in a composite outcome that included onset of a persistent 50% or more reduction in eGFR from baseline, onset of a persistent eGFR of less than 15, initiation of dialysis, or death from either kidney or cardiovascular causes. Now, Ozempic's benefit was largely driven by reductions in eGFR reductions of greater than 50% and cardiovascular death. So essentially, it caused kidney decline to slow over time and also contributed with lowering cardiovascular death. Now, this expanded indication now places Ozempic alongside SGLT2 inhibitors like Farxiga and Jardiance as recommended therapies for individuals with type 2 diabetes and established kidney disease. So it's always nice to have extra options for CKD and diabetes. Now, in vaccine news, the FDA has required 2 RSV vaccines, those being Abrysvo and RXV, to include a warning in their prescribing information about an increased risk of Guillain-Barré syndrome after vaccination. This was based on a post-marketing observational study that found an estimated 9 excess cases of GBS per million doses of Abrysvo and an estimated 7 excess cases of GBS per million doses of RXV during the 42 days following vaccination. The FDA also went on to approve Penmenvy, which is a meningococcal vaccine covering groups A, B, C, W, and Y. It joins Penbrea as the second pentavalent meningococcal vaccine on the market. Not too much moving the needle with that one, but it is always nice whenever you can kind of get fewer injections if you can, kind of putting them all in the same injection. There were also 2 big pieces of news that were particularly relevant to our correctional clients. The first is that the FDA approved a rapid initiation for Sublocade, which is the once-monthly buprenorphine injection for opioid use disorder. Now, previously, patients had to be stable on a transmucosal buprenorphine dose of 8 to 24 milligrams per day for 7 days before starting, which made it kind of difficult to start in a transient location like a jail. Now, however, individuals who are not already receiving buprenorphine can receive an initial dose of 4 milligrams of transmucosal buprenorphine, undergo observation for an hour just to confirm that they tolerate it and they weren't sent into withdrawal, and then receive their initial 300 milligram injection of Sublocade. Now, on induction day, patients can receive up to an additional 8 milligrams of transmucosal buprenorphine if needed to manage any emergent withdrawal symptoms. Patients are then given a second 300 milligram dose of Sublocade as early as 1 week and all the way up to 1 month after the initial injection. And they say that it's based on patient need, so it's not a standard schedule. After the first 2 injections, the patient should receive monthly injections of 100 milligrams, although they could receive 300 milligrams monthly if the 100 milligram dose isn't sufficient to stave off cravings and withdrawal. So I think this is going to provide a big help for a lot of our correctional facilities to help, especially with there being a push to get individuals on these longer acting agents to improve adherence and reduce recidivism. So I think this is going to be a big feather in the cap of Sublocade.
Yeah, and we've talked.
And finally,
I was going to say, Chris, we've talked at length about medication-assisted treatment on this program. I think your first episode ever as a guest was talking about it, if I remember. And more recently, we talked about expanded access to it through the MAT Act and so on. But it's great to see another barrier of sorts removed, as you said.
Yeah. Anytime you can get someone on something that acts a little bit longer, a little easier, I think that's a big thing. And like I said, I think it's going to go a long way for the jails where you really only have a very limited amount of time with these individuals in some cases. So should be exciting moving forward. And then finally, not to rant too long, the other piece of news is the FDA's elimination of the clozapine REMS program, which has been very exciting. Historically, in order for the pharmacy to be allowed to dispense clozapine, both providers and patients needed to be enrolled and patient lab work needed to be reported to the REMS program. So essentially, the removal of this program means that patients and providers no longer need to be enrolled. Absolute neutrophil count results no longer need to be reported. And essentially, pharmacies can dispense without restriction. Now, that being said, the risk of neutropenia still exists with clozapine, so providers should still follow the monitoring that is outlined in the prescribing information per the FDA. This just basically allows for fewer hangups and in terms of dispensing, and will potentially lead to fewer therapeutic delays. So I think that'll be a big help for facilities.
I would imagine that was some big news for you all in the optics team with this clozapine REMS.
Yes, and it still is. A lot of facilities are excited because a lot of times, just to peek behind the curtain, a lot of times patients will be started on these in a psych hospital, and then they'll be transferred to the jail. But then in order to continue prescribing it, before that, the provider in the jail had to be enrolled. And for some, this may be maybe the first time they've ever prescribed it. So we were often met with situations where the patient was sent to the jail quite abruptly. and there was no one in the facility to order the medication for them. So we had to do a lot of education on how to get them enrolled and everything. And basically just created a lot of hangups, a lot of delays in therapy. Whereas now, yes, we still have to drive the point home that, hey, as a prescriber, from like a good health, just from a good practice perspective, but also a liability perspective, yes, you do still have to be doing the monitoring. It's just that no one is policing it or stopping us dispensing. So it's going to help us expedite and avoid delays in care. But again, it's going to still require some education that, hey, just because the REMS is gone doesn't mean that the risk is gone as well. So it'll be an interesting thing to see how it rolls out moving forward.
Let's take a quick break.
Everyone knows that pharmacists dispense medication, but the clinical pharmacists in Diamond Pharmacy's optics team dispense more potent resources, information, and education. The optics pharmacists are frontline medication experts for Diamond's many institutional partners. Whether you work as a provider in corrections or long-term care, the optics team is standing by to answer your on-demand medication questions. But optics is far more than a drug information hotline. They also create proactive knowledge resources like webinars and this podcast to keep partners up to speed with the latest drug developments. And they help providers to better manage costs and therapeutic outcomes with their in-house medication surveillance monitoring program. Learn more about the optics team by going to diamondpharmacy.com and clicking the clinical support tab. See pharmacy care more clearly with optics. Let's get back to PodcastRx.
So, Chris, you're heading back to NCCHC in a couple weeks for another presentation. And what number of presentation is this for you? How long you been doing this? And it's quite a few, right?
Yeah. So I think this is my 6th year presenting. So I started in 2019 with my first presentation, I believe. So I think this is my sixth topic. I've done a couple of them, repeats through like their virtual presentations as well. So yeah, I'm looking forward to it.
Sure. And this is in Louisville, Kentucky, or Louisville, or there's actually a section in the conference program that devoted to how exactly you say Louisville.
I better brush up on that part then.
Yeah, I don't know what the correct is, but we'll just keep it above the Mason-Dixon line. Louisville. Have you been to Louisville, Kentucky before?
No, I actually haven't been. So I'm really excited to check out the city. Go check out some of the food, all that good stuff. Unfortunately, I did see the Kentucky Derby isn't going to be happening until the following month. So unfortunately, I'm going to be missing out on that. So I can leave my big hat at home.
Yeah.
But yeah,
no
I'm looking forward
for
to.
You.
yeah, exactly. But no, so like the city should be good. I always like it whenever it's in a place that I've never been. Gives me a little extra something to spice up the trip. But the actual conference itself, like I'm very I'm looking forward to the actual conference itself. It's always just like a really nice time, seeing a lot of familiar faces, going around, seeing all the seeing some presentations if I have time, and having people stop by the booth and whatnot. It's always a really interesting experience.
No doubt. Well, let's get right to the important stuff here. What is your presentation focused on this time around?
Yeah, so this year I'm very excited. I'm going to be discussing the management of overweight and obesity.
Really doesn't come as a surprise to me, given how much we've talked about GLP-1s on this show. I imagine that's going to be a big part of your presentation. But what exactly led you to focus in on overweight and obesity in the corrections environment?
Yeah. So, I mean, in previous years, I've presented on a variety of topics. As you know, as listeners may know, I've talked about things like respiratory diseases, hyperlipidemia, and even nutritional supplements. But like none of them felt so applicable to so many people as would a discussion on weight loss. And I started thinking about this immediately right after my presentation last year. And this was right around the time where we were seeing the explosion in popularity of the newer weight loss drugs like semaglutide and tirzepatide. That's really been going on for a couple of years now. But as we've seen these drugs enter the mainstream media, social media, many individuals have started using them themselves, and I'm sure many more at least know someone who is using them. And if you add that to the fact that rates of overweight and obesity are increasing, not just in corrections, but the US as a whole, I kind of thought it would be a good time to provide some education on not just these fancy new drugs, but weight management as a whole, because I think that a lot of people, for better or for worse, they're quick to reach to the GLP-1 medications, which work really well. But I think there's something getting lost underneath that in terms of lifestyle stuff, general education on that, as well as like, hey, there's other medications as well that may be less costly. So I think just like an all-encompassing presentation was kind of needed on that.
Well, we talk about disease states and ailments that are more prevalent in the incarcerated setting. HIV, hepatitis, substance abuse disorders all come to mind right away. But when we're talking about overweight, obesity, just how prevalent are they in the incarcerated setting? Do they reflect the broader trends in the community? What does the available data say on those?
Yeah. So as we touched on in previous episodes, I'd said that correctional health data is often lacking. So it can be a little bit tough to get a good read on things at times. However, I did find a recent analysis that suggests that the rate of obesity is 30% in incarcerated men and nearly 40% in incarcerated women. Now, when you compare that to the national average of 42%, you'll notice that rates among women are pretty comparable, but the rate of obesity in incarcerated men is a fair bit lower, which honestly, I wasn't really expecting that. Given that rates of chronic diseases are typically comparable, if not higher, in corrections. But despite this lower prevalence, there still is data to suggest that weight gain does occur during incarceration, meaning that if it's not a problem upon entry, it could become a problem after a sufficient length of stay.
So with your presentation, then what exact areas of overweight and obesity management will you be touching on?
Yeah, so I probably casted a wider net than I had to. I really tried to cover all aspects on the topic. So as background, I'm going to be discussing what really underlies weight gain, as well as like some of the physiological mechanisms about how the body resists weight loss. I'll also be discussing screening and prevention, which will obviously include a decent discussion on lifestyle modifications. I then move into a discussion on how to diagnose overweight and obesity and how to treat it, both with lifestyle interventions and medications. And of course, it wouldn't be a pharmacy presentation without a deep dive into the various medications that we have available. I'll be reviewing the basics of each medication, reviewing how well they've worked in clinical trials, as well as providing some tidbits on when to consider one agent over another, which might be helpful. And then also one area that I'll be addressing that I felt was really important was what to do after starting a particular therapy. Namely, when do you cut bait if the medication isn't working, and even how to manage weight loss plateaus after a stretch of successful therapy, which, can be fairly common and it can be difficult to break through. So kind of, providing a bunch of information in a holistic fashion. I really wanted to kind of go from A to Z on this topic as best I could in the time frame allowable, of course.
Right. And regarding that last point regarding plateaus, that does seem really important. I would imagine that it's easy for if something worked initially, it's that inertia could set in and you're not questioning it to change it up with something else. Just that, well, it worked before, it was working fine. Why change it? Is that true?
Exactly. And like I talk about in the presentation, the body is going to resist weight loss. It's an evolutionary adaptation. Basically, you don't want to lose too much weight. And even with the GLP-1s, you do start to hit plateaus. It differs for everyone, but in that 12 to 18 month range, that's when you can really start to see it. And that's where you need to kind of shake things up a little bit. I talk about, of course, honing in your lifestyle modifications, which is going to be the primary thing. Don't out-eat the medication, because you can actually adapt to how the medication makes you feel. And even though for quite some time, the medication was limiting your hunger or your desire to eat, eventually you become used to that and you can start to out-eat the medication once again. But also, too, it's not really addressed much in the guidelines, but you could also, there's also concepts such as like medication cycling, jumping from one mechanism of action to another drug class, or even potentially combining medications. So these are all different things that I kind of bring up in a way to kind of get us thinking about how to handle that.
Well, of course, we're talking about the GLP-1s. It's going to be a big part of your presentation, no doubt. Revolutionary treatments, of course, and all the inroads that you mentioned, social media, pop culture. We're seeing these everywhere. But in the corrections environment, what's the general uptake of those right now?
Yeah, and just as an aside, that's one of the big reasons why I chose this topic as well, is because I figured that everyone wants to know more about the GLP-1s, and I figured a discussion on weight loss and obesity is going to be it definitely relies more on a discussion of the GLP-1s. So I figured might draw a good sized crowd to come here and talk about these. But I would say that progress, generally speaking, at least with regard to using I would say with regard to weight loss drugs in general, has been slower in corrections than in the community. I was running some numbers and I'd estimate that around 0.005% of our patient population is on a weight loss medication currently. And that's not just limited to the GLP-1s, that is all of them. And when you compare that to a community estimate of 1.3% from 2019, and you think 2019, that's even before the explosion of the popularity of the recent popularity of drugs like Wegovy and Zepbound. I can't even imagine what the percentage is now. And to be honest, I wasn't able to find a good estimate of that in preparation for the show. And but this lagging, I don't think is atypical. The correctional focus is often more on stabilizing patients and treating the most emergent health conditions while also working within budgetary constraints. Remember, these newer medications aren't cheap. With a minimum of about $1,000 per month, depending on which product you're looking at. And another thing to consider is that a large portion of corrections is the jail population, which is often quite transient. So an individual's obesity medication from home may not be continued in the jail, just considering that they may be returning home in a week or two.
One facet of your presentation is the preparation of correctional facilities to manage patients on these agents. So what steps are correctional facilities have had to take, or are they having to take as these new treatments take hold?
Yeah, so I think the most notable consideration is going to have to be cost, especially whenever we consider again the newer agents, particularly the GLP-1 agonists and the dual GIP-GLP-1 agonist. It may ultimately be the case that not every person who qualifies for treatment can receive it. Which is basically what we see in the community. Because take, for example, let's say like a 2,000 bed facility. If we call back to that 30% obesity rate in males, and just to use that as a low estimate, and you consider a monthly cost of at least $1,000 for these newer injectables, well, then you're looking at a monthly cost of $600,000 just for weight loss treatment, which could clearly, quickly become unsustainable. So I think at least when it comes to the injectable therapies, the newer, more expensive injectable therapies, the facilities may need to stratify individuals according to risk, with higher risk individuals preferentially receiving injectable therapy. They could also consider the use of lower cost oral agents, either exclusively or as a form of step therapy before progressing to the injectables if needed, because some of the oral therapies can often be quite effective as well. However, it will have to be balanced with the fact that some of the oral medications are controlled substances, which we typically avoid in corrections due to diversion concerns. But really, what I think underlies all of this is that facilities are going to need to first focus on providing an environment suitable for lifestyle modifications to promote healthier eating habits, which can really be a challenge in corrections.
Yeah, and for all that you could talk, we could talk about the pharmacologic options. Yeah, your presentation devotes plenty of time to non-pharmacologic treatments. So, but really,
Yeah.
how easy is it to implement these non-pharmacologic options in a corrections environment?
Well, let's be real. It's hard to implement even in the community. But generally speaking, in a correctional environment, they're even more difficult. I mean, first and foremost, we have to consider the fact that incarcerated individuals are often under a high amount of stress, both because of their current legal situation, but also simply because correctional facilities in and of themselves can be stressful environments. And of course, stress has been shown in many cases to increase caloric intake, and also worse than that, shift one's food preferences to those that are hyper palatable, those being more like ultra processed foods. So you think like cookies and chips and all of those like comforting like sort of junk foods kind of thing. And obviously many of these can easily be obtained via commissary in the facilities. Now, that being said, I am aware facilities do typically have different meal plans for the general population, as well as populations that require special diets. Like they have lower calorie meal plans and lower sodium meal plans. They have diabetic or cardiac diets. So they do a good job of providing a particular meal plan for a particular individual if they need it. However, given that ever-present access to commissary, just as you and I have to be in the community, individuals will have to be mindful of their food choices outside of their provided meal plan.
Right. And it's not like there's, a nutrition coach or dietitian, assigned or available in these settings to, keep you on the right track either.
Right. And for the listener, for those maybe unaware, a typical commissary food options are kind of akin to what you would see at like a gas station down like the snack aisle and stuff like that. So it's not hating on any of it, but it's not the best food for you, particularly if you're trying to lose weight.
Well, your presentation is going to cover a lot of ground. And I guess my next question for you is, what do you hope, though, with all of that you're going to cover, what do you hope will be the most important takeaway as you discuss overweight and obesity management in the corrections environment?
Yeah, I guess just like the biggest thing is I'm hoping to convey that obesity is a chronic disease that is worth addressing, just like we would hypertension or diabetes. Specifically, my goal is for attendees to leave the presentation with a better understanding of the various underlying factors that contribute to weight gain and kind of how to address those as part of a comprehensive treatment plan. Additionally, I hope to instill attendees with the confidence to discuss and promote lifestyle modifications with their patients. And then if needed, make appropriate medication choices for their patients, based on one's comorbidities or the degrees of weight loss that they need.
In the past episodes where we've talked about your upcoming presentations, you've mentioned the familiar faces in the correctional healthcare world, friends, acquaintances that you've made at these shows. Has anyone reached out early about your topic? Are you expecting a nice crowd?
Actually, I haven't heard from anyone yet, but it's usually a fairly consistent cast of characters that attend these events. So don't worry, I'll be making my rounds around the exhibit hall. But I do, in terms of turnout, I kind of, like I had alluded to, I wanted to do this discussion after my last presentation because I wanted something that could potentially have a big turnout. So it is my hope that it is a big turnout because, again, like I said, I think this is a topic that everyone can gain at least a little bit of something from. And if nothing else, just kind of come out, hear a little bit about the GLP-1s, see where they fit in therapy and kind of go about their day. So I hope it'll be a nice turnout for sure. But I'll be happy with anyone. Trust me, I've presented to 2 people before. And if it's 50 people, 2 people, 1 person, it doesn't matter. I will still give them my best.
Well, anyone listening and you're going to NCCHC, please give Chris more than an audience of 2. Okay. I'm sure they'll have no problem there. But for anyone headed to NCCHC, Chris, go ahead and provide all the details for your presentation so they know where to find you.
Yeah, so my presentation is number 126, entitled "Worth the Wait: Obesity and Overweight Treatment," and it's going to be on Monday, April 7th, from 4 to 5 p.m. And also, when I'm not presenting, I will be at Diamond's exhibit booth for the entirety of the conference. So if we have any listeners attending, feel free to stop by and say hello.
And for the record, Diamond's booth is 500 in the exhibit hall. Right next door is also our friends at Sapphire Health, Sapphire EHR, booth 502. So definitely come by, talk to Chris, talk to Sapphire, everybody. And Chris, we're going to make sure we definitely have plenty of optics literature for you to hand out when you're talking with everybody. So, yeah.
Fantastic.
All right. Well, we're going to take another quick break. We'll be right back with a quick trivia capsule.
In the realm of corrections health, not all electronic health records are created equally. Sapphire EHR is a comprehensive, cloud-based electronic health record designed specifically for correctional health providers. Since 2011, Sapphire has worked one-on-one with healthcare staff in jails and prisons to develop and refine a suite of features and modules to manage total inmate patient care. From MedPass to dental care to documentation of lab results and creating custom forms, Sapphire's correction-specific features can be scaled to meet the needs of the largest correctional facilities down to the smallest local jails. And it's all backed up by 100% in-house hosting, training, and support, with a 24/7 help desk. Get a closer look at the Corrections EHR deployed in over 400 facilities across 36 states and territories. Visit www.sapphire-health.com and schedule a demo today. Sapphire EHR. Cloud-based, compatible, correction-specific electronic health records. Now back to PodcastRx with Chris Bender.
All right, Chris, what mind-blowing medication trivia will you leave us with today?
Well, longtime listeners will know that I'm a big fan of the GLP-1 agonist and may even recall a bit of trivia from one of our previous episodes where I explained how the first GLP-1 agonist, exenatide, was actually derived from Gila monster venom. But did you know that many other medications have been derived from animal venom? Well, captopril was the first ACE inhibitor to be developed. It was synthesized to mimic the effect of a peptide found in the venom of the Brazilian pit viper. Nowadays, ACE inhibitors are one of the most common and effective therapies for hypertension. Next is ziconotide, which was derived from the toxin of the cone snail after it was found that this toxin blocks pain signals from reaching the brain. Ziconotide isn't commonly used as it can only be administered intrathecally, which means directly into the spinal fluid, and is only approved for severe chronic pain for which other treatments have been insufficient. And last, we have eptifibatide, which is derived from a peptide in the venom of the southeastern pygmy rattlesnake that prevents platelet aggregation and is now used to prevent blood clots during coronary artery procedures such as percutaneous coronary interventions. And yet others could still be on the way, as other peptides from venom are currently being studied. These include spider venom to prevent brain damage after a stroke, or even treat Dravet syndrome, which is a severe form of epilepsy, scorpion venom to better visualize cancer cells, and tarantula venom to actually kill cancerous skin cells.
Always fascinating when science can reverse engineer these naturally harmful and, quite frankly, terrifying substances for the benefit of human health. Can't wait to see what they come up with.
It's amazing. And one thing that I was seeing in preparation for the trivia capsule is basically things have gotten a lot easier, because in the past they used to have to literally milk a snake to get sufficient amount of venom in order to isolate compounds and study it. But now we just have a database. Thankfully, due to modern technology, we have a database of all of the different toxins and peptides and whatnot out there, and we can just run computer programs to see which peptide would probably work in which situation, and then they can just recreate that in the lab. So the process has it's pretty mind-blowingly quick and efficient now. So it's very exciting. We may see a lot more of these moving forward.
Yeah, and definitely glad that no one has to milk a snake for it.
Amen. That's a great way to wrap up.
Chris, thanks again. I'm glad we could finally catch up this month. Best of luck with your NCCHC presentation, and wish you the best time in Louisville, and hope you get lots more than 2 people to come see you.
There we go. Thank you so much. I appreciate it. I'm glad to be back with you, and I'm looking forward to the next one.
Absolutely. And again, if you're attending the National Commission on Correctional Healthcare Conference, Spring Conference in Louisville, Kentucky, look for Diamond Pharmacy, booth 500 in the exhibit hall. And once more, Chris's presentation titled Worth the Wait, Obesity and Overweight Treatment, happening Monday, April 7th from 4 to 5 p.m. It's going to be a good one for sure, so please check that out. And again, if you like this show, if you like PodcastRx with Chris Bender, do make sure that you like, subscribe, follow, leave us a review where you can. We're in a lot more places now, and we appreciate every one of you that listens month in and month out. So until next time, Chris, take care, and we'll see you again soon.
See ya. Take care.
PodcastRx features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as the substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services. Find our show on Apple Podcasts, Spotify, YouTube, or wherever you enjoy podcasts. And where possible, please rate and review. If you'd like to get in touch with the show directly, shoot us an email at podcastrx@diamondpharmacy.com. Thank you again for your support.